Our next speaker is Dr. Cynthia Moore. Dr. Moore comes to us from Atlanta. She has a distinguished career working in genetics and epidemiology. She did her MD and pediatric training at the University of Tennessee. And she did a PhD and a fellowship in medical genetics at Indiana University School of Medicine. And so she's a clinical geneticist who currently works as the Chief Medical Officer for the Division of Congenital and Developmental Disorders in the National Center on Birth Defects and Developmental Disabilities at the Centers for Disease Control and Prevention. So Dr. Moore has been to GGC before, shared her expertise with us, and she's going to talk with us today about teratogens. Dr. Moore.
Thank you. Everybody hear me? Okay, good. Well, I am delighted to be here again, both in Greenwood and at the Genetics Center. And so thank you for the invitation. When I was hearing Dr. Skinner's opening, I thought, this is like deja vu all over again, because this is my topic and I have 15 minutes. Maybe I would have picked another one, I don't know. But actually, in the last 4 years, I've been immersed in teratogens first, since the end of 2015, thinking about Zika virus and the teratogenic effects of that virus. And most recently, since May, working on a safety signal for rather new HIV medication, an antiretroviral, which has had a preliminary association with neural tube defects. So that could have a big impact on programs all over the world. So I think it's probably appropriate. I hope I do a good job. I started out, as you did, Steve, thinking about what's the definition, and I was really surprised how many definitions of teratogen there are. And so I like this one, maybe because I did some modification of it, but it's an agent that can disturb the development of an embryo or a fetus, and often the fetus part is not there. I'll break this down just a little bit for you. When we look at agents, typically or historically, they've been broken down into 4 categories: the physical agents, those who have medication and other chemicals, maternal conditions, and infectious agents. And we look at disturb the development. That doesn't tie us down to any one effect. Today we're talking about structural birth defects. Those can be isolated or multiple. They can be major or minor. They can come in a recognizable pattern. If you're good like Dr. Hawley, can recognize the pattern. And a lot of times those minor structural birth defects are the ones that help us with the pattern, either trying to describe something new or working with the patient to see if we can determine something that's already known. And then neurodevelopmental disability is a very big category, and we do work on that also at the CDC. And honestly, when parents come in or pregnant women come in and ask about, what are the problems my baby's going to have, they think about birth defects, they think about neurodevelopmental disabilities, they think about the whole ball of wax. So we try to do that. And then disturbing the development of an embryo or fetus. So again, as I said, we're talking about structural birth defects today. This diagram came out of I think a landmark publication in 1982. Maybe landmark for me, because when I first saw this, I thought, I finally understand all these different categories and what they mean. Most of the time when we're talking about teratogens, we are talking about malformations or some problem that started at the very beginning. We may be talking also about disruptions, that the start was good and then something came in and kind of threw it off for the rest of the developmental period. And of course, when we're thinking about this, we have to think about developmental timing. When is a particular organ system developing? And tissue vulnerability. There is a great resource that I didn't put in here, which is from Moore's Embryology, where you can see the whole gamut of when different organ systems are developing and the timing there. what I did put in was my sort of modification of it. This is for epidemiologists, especially for infectious disease epidemiologists, because this was a whole new world for them working with Zika. So basically just showing that there are a number of outcomes that can happen with a teratogen, and especially with a congenital infection like Zika, that there was a lot of shock that we weren't talking just about malformations happening early in the first trimester, that there was possibility for damage all the way across, or for an effect all the way across. Also with Zika, we found that there were problems even going into the third trimester, which was also different. And we don't really know the developmental disabilities part yet, and we have a little information on the adverse pregnancy outcomes and early pregnancy loss, but we still have a lot to learn there. So there also is a process of determining whether we think an agent is a teratogen. Maybe 2 years ago, a colleague from CDC came and presented that here on Zika virus infection. Not going to have time to go through that either, but we do go through those steps of thinking about what it is that makes us think this association is a real one when we encounter something new, like Zika, or this new association, possible association with an antiretroviral drug. Also, I have to think about both the individual patient, because I still see patients, but in a bigger sense, the rest of us in my group thinking more on a population level. And if we look at, think about the impact of current teratogens, and there was another request to think about that too, so that got my brain moving. Really, I think about the magnitude of the risk given the exposure, and also the probability of an exposure. This is very simplistic, but sometimes my mind is like that, and I just divided it into sort of levels of risk and levels of exposure, thinking about where different types of teratogens would fall, such as strong but rare, which is thalidomide, weak but common, smoking, and diabetes being somewhere in the middle. And we could all quibble with where something goes, but it helps me think a little bit more about what should rise to the top when we're thinking in a public health manner. And these pluses just designate the areas I think are more, that we look more in public health, and we do look at common and weak exposures, especially if these are things that we think are easily avoided and the birth defect is prevented. We don't spend much time in the rare disorders. So going back to the impact of teratogens, thinking about the risks, this is a paper that was done a few years ago with the folks working with Teras. And they looked at all the evidence for teratogenicity of medications in pregnancy, all the studies. There of course are a lot of case series, there's some cohorts, there's registries, there's some epidemiologic studies that look at odds ratios. And this little figure over here is from our program, which we're called Treating for Two, when we think about medication use in pregnancy, and fewer than 10% of medications have enough information to determine the fetal risk. And that came out of some of this work, although this was closer to like 97%. It's really shocking how little we know. It was shocking to the folks in the HIV world when we gave them that fact, because they thought, oh, we should know all of this, and we don't. And every day medications are prescribed for pregnant women for which we really don't know the risk. Go. And then trying to put some handle, some arms around, I guess, the exposure that you could expect. And you can look at this in the US, you can look at it globally, you can find lots of different numbers. I went in to see what I could find. There's a nice article on the top 200 prescribed drugs in the United States. And if you see down there, warfarin, which is a teratogen, is number 42. I kind of feel like this is back when we were looking at songs. I don't know if it has a bullet or not, but it's right there at 42. Then there are a lot of papers that are patterns and use among women of reproductive age, among women who are not pregnant and compared to pregnant. And there's some sources for that we use over and over again, like the National Health and Nutrition Examination Survey, or NHANES, which does come out of CDC. So I want to jump right into the teratogens. First classification I was looking at is infectious diseases. And I think one of the hallmarks here that everybody's heard of is a congenital rubella syndrome. The chance of a congenital infection is somewhere between 50 and 85% with first trimester infection, and you know that goes down, and the risk for birth defects goes down to very small after about 20-some weeks. The estimation is 100,000 infants worldwide are born each year with CRS. Now, fortunately, we can say in the Americas, this hemisphere, vaccination has pretty much taken care of that. We certainly get women coming in from other countries. One of the areas that really hasn't embraced vaccination is in Africa. And so it's not that you won't see this, but it's not the epidemic in the United States that happened over and over until vaccination. And the structural birth defects that are sort of the triad here, and I think I could even argue if they really fit structural, but it's microcephaly, patentosis, icteriosis, and cataracts. And in microcephaly, I guess I've always just said, okay, microcephaly is one of those features. But when it came to looking at Zika, the question was, why are they microcephalic? What are the structural anomalies or the change in the brain that leads to microcephaly? I was able to find just a few things for congenital rubella where there had been imaging, and it looks to be due to some malformations of the cerebral cortex, and cerebellar hypoplasia as another defect. We did in our group at CDC, along with one of our colleagues at Emory, did an update on the cardiovascular malformations in congenital rubella. And so we found that PDA is really not the most common. It's a branch pulmonary stenosis, happens twice as often in reports as PDA. So here are the other congenital infections that we have to pay attention to. For time's sake, I highlighted that most of these have brain and eye defects, and some of them are pretty pathognomonic. Zika is a little different in that you also see spinal cord problems with Zika, which leads to arthrogryposis. And the latest thing that we're trying to publish right now is some workup on paralysis of the diaphragm, which is a peripheral nerve problem that comes with Zika, which is also a little different. We're seeing pretty stable CMV rates. Zika is episodic. We don't know when we'll see it again, maybe never, but we predict if it's like its other viruses in its family, it will come back again. Syphilis is just going out the roof right now, especially in the United States. Toxo, I think, has been pretty stable. Moving on to what I think most people think of as teratogens, which are the medications and the chemical exposures. I pulled out valproic acid. It is, as you know, approved for epilepsy, some types of bipolar disorders, and for migraine prophylaxis. One of the things that you can see in that line is that this may affect a lot of women of reproductive age, because they certainly get those last two, I think, more frequently, perhaps, or other psychiatric disorders more than epilepsy, and that there's been a move away from valproic acid for epilepsy. But there is widespread use, and on the top 200, it hit 120 of the U.S. drugs prescribed. Of course, that's not broken down by age or sex. So there have been studies that looked at the risk for birth defects, relative risk of about 3 when you compare, this is in total, birth defects to other anti-epileptic drugs, and 3.8, almost 4 when it's compared with risk in the general population. Now, this paper in the New England Journal a few years ago looked at the risk of specific birth defects, And the odds ratio of having a spina bifida and valproic acid in this study, which looked at a bunch of cohort studies, was 12.7, very high, and 6.8 craniosynostosis. These are down at the lower part of the screen are all the ones that they had numbers to look at, and there's some there that are missing. For example, the radial aplasia is shown in this paper by Jill Clayton-Smith. And the craniosynostosis is pretty particular or specific to trigonencephaly or the metopic procedure. These two defects weren't known at first, and I give myself a little bit of comfort for that because many years ago I misdiagnosed a child as having Ballard-Gerald syndrome, which has trigonencephaly and radial aplasia, thinking that hadn't been shown in valproic acid. So I too go back and try to find that family and talk to them about what now we really think was going on. Other medications, as Steve said, there's some classes of birth defects that you see over and over again, cardiovascular being one of them, orofacial clefts being another. But there are some very specific structural anomalies or birth defects that are seen with different types of teratogens. For example, everybody knows about the limb deficiency, the phocomelia, enthalidomide, the nasal hypoplasia that's in warfarin, the possibly Epstein's anomaly in lithium, for example. And if we look at this list, and I'm sure I left off somebody's favorite because there are more, these are the drugs that were on the list of the most prescribed in the United States. The one that gives me pause is topiramate or Topamax, which is an anticonvulsant, but it's been used now quite a bit for migraine prophylaxis. And the latest labeled use was taking this drug and combining it with pheneramine, which is part of Finbin, if you remember that diet, as a new diet drug because the topiramate has been shown to cause weight loss. So you're taking two things that may be a teratogen and you're giving it perhaps to people who may have weight problems. So it seemed like a kind of a different kind of thought, although we know obesity is a huge problem in this country. And then the three that are highlighted in blue, isotretinoin, thalidomide, and warfarin, at least in studies, have been shown to have more than 25% of babies who are exposed having some of these structural birth defects. Is probably higher, but that's what the numbers show in studies. So I'm not going to go over some of the other medications and chemicals. Of course, alcohol is a big one, so is smoking. We are looking at opioids now. There have been some association with clefts and gastroschisis. And trying to explain maybe why gastroschisis is on the rise. Are there things in the environment we haven't thought about as much as being associated? In fact, with gastroschisis, we've not had a whole lot of luck finding out what those factors are. And then some physical agents listed here. And moving on, the last topic is maternal conditions. Of course, pregestational diabetes has to go on the top of the list there. There are estimates that 1.8 million women of reproductive age in the U.S. Have pregestational diabetes. These are not women who are pregnant. This came out of the birth defects risk factor study. Affects 1 to 2% of pregnancies. Birth defects in 5 to 10 of exposed pregnancy. I think that insufficiency was me doing a spell check. Sorry about that. And broad range of birth defects, including cardiac defects, neural tube defects, and sacral agenesis. Kind of an interesting fact, we are redoing out of the National Birth Defect Prevention Study, which Steve mentioned, we are looking at diabetes, pregestational diabetes again. And as an isolated anomaly in that, of course, with really small numbers, sacral agenesis comes out with an odds ratio of about 800. That is phenomenal. phenomenal. You've never seen anything like it. And then, of course, we have to put obesity in there. There are estimates by 2025, more than 21% of the women in the world will be obese. And we know that there's a 5-fold increase, and some are higher than that, with some of the usual suspects: neural tube defects, cardiac defects, orofacial clefts, and limb deficiencies. So I think I'm coming, let me look for sure, to the end of my list, and somebody is going to say, okay, where's folate? Where's folate insufficiency? That's why I did the spell check. And Godfrey's sitting here, Dr. Oakley, who's going to talk about that. And I tried, I think, to explain when I was to Roger's, like, well, teratogens are things that are added in. So how do I think about folic acid, although I know that insufficiency is one of the biggest causes of neural tube defects and perhaps other birth defects in the world. So I tried to come up with how I would describe it. These are not great, but you may use them if you want. Try anti-teratogen, reverse teratogen, or teratogen in absentia. If you've got other ideas, let me know. But of course, folic acid, folate is extremely important in the prevention of defects. And that's it. And any questions, I will be happy to take. Thank you for your kind attention.